CT/CT is highly sensitive, 94 to 98%, and specific, up to 97%, for the diagnosis of acute appendicitis and allows for alternative causes of abdominal pain to be diagnosed. The need for contrast, IV, oral, or both, is debatable and varies from institution to institution. Oral contrast has not been shown to increase the sensitivity of CORT. Nonetheless, many radiologists advocate the use of oral contrast in patients with a low BMI, less than 25. IV contrast medium can demonstrate the presence or absence of infarction. CT findings include: appendiceal diameter is increased in acute appendicitis. O is greater than or equal to 8 to 9 mm. Outer to outer diameter has been suggested as a cutoff value, but note this overlaps with the upper limit of normal appendiceal diameter, less than 13 mm, wall thickening, greater than 3 mm. Enhancement and stratification if no gangrene, thickening of the cecal apex, cecal bar sign. Arrowhead sign, periappendiceal inflammation. O fat stranding. O thickening of the lateroconal fascia or mesoappendix. O extraluminal fluid, especially if complex. O phlegmon, inflammatory mass. O abscess, focal wall. Non-enhancement of necrotic segment, gangrenous appendicitis, a precursor to perforation, the presence of intraluminal, intramural or periappendiceal gas locules with an obstructed appendix strongly suggests necrosis, gangrenous appendicitis. Less specific signs may be associated with appendicitis. Appendicolith, high risk of perforation. Periappendiceal reactive lymphadenopathy. MRI is recommended as the second-line modality for suspected acute appendicitis in pregnant patients. Where available 14-15. Protocols vary widely, but most include imaging in 3 planes with a rapidly acquired T2 weighted sequence, and some include T2 fat-suppressed imaging. MRI findings mirror those of other modalities, with luminal distension and widening, wall thickening, and periappendiceal free fluid. Treatment and prognosis. Treatment is appendectomy, which can be performed either open or laparoscopically. Mortality from simple appendicitis is approximately 0.1% but is as high as 5% in perforation with generalized peritonitis. In approximately 30% of cases where the appendix has become gangrenous and perforated, initial non-operative management is preferred provided the patient is stable. In this situation, radiologists have a therapeutic role to play with percutaneous CT or US-guided drainages of periappendiceal abscesses greater than 3 cms. Smaller collections may be managed with antibiotics and interval appendectomy. Complications. Recognized complications include perforation in 10 to 20% of cases and suggested by peritonitis and imaging findings. Most specifically, appendiceal abscess or extraluminal gas. Also periappendiceal phlegmon and fluid. Generalized peritonitis due to free perforation, pylophlebitis. Infective thrombophlebitis of the portal circulation, hepatic abscess, necrotizing fasciitis. Differential diagnosis. Clinically, the most common differential is that of mesenteric adenitis, which can be differentiated by the identification of a normal appendix and enlarged mesenteric lymph nodes. The imaging differential includes inflammatory bowel disease, especially Crohn's disease, which may affect the appendix, other causes of terminal ileitis, appendiceal mucocele, lymphoid hyperplasia, pelvic inflammatory disease, PID, right-sided diverticulitis, appendiceal diverticulitis, mechal diverticulitis, acute epiploic appendicitis, omental infarction, appendiceal endometriosis, appendiceal malignancy, obstruction by appendiceal or cecal tumor, isolated, appendiceal submucosal lipomatosis, Valentino syndrome, from perforated peptic ulcer.